Hey, I'm making my own way, but I stumble and I falter every day. But I love my baby now. But I love my baby, I'm still learning how. Hey, 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 I'm okay. Stay with me. We'll beat these
Hello, welcome to another edition of Pathways to Parenting Success. I'm your host, Dr. Jan Hittelman, licensed psychologist, director of Boulder Psychological Services. It's my pleasure to be with you today to discuss a very important topic, diagnosing and treating mood disorders. Some of you may be watching this show archivally, but those of you that are watching live or that are seeing it during the month of October 2014, I want to let you know that we've been putting a lot of effort this month into focusing on this important subject of depression and suicide reduction. We had a very grim reminder that this is a problem in our community in that just last month we lost a teenage high school student here in our community to suicide. And I'm very excited to be able to provide this information to the community. And because of the importance of this topic, all month long we are doing a variety of talks that relate to depression. And I just want to briefly let you know about some of those talks coming up. And I'll have a slide for you a little later with this information as well. We'll be at the Broomfield Library on October 20th next week to talk about teen depression, what's normal and when to seek help. On October 21st, we'll be at the Louisville Library, and the subject there is feeling down, helping adults manage depression. And then finally, we have a talk at the Meadows Branch Library in Boulder on October 27th entitled Children Get Depressed Too, How Children Can Improve Their Mood. I also want to let you know that just yesterday we had a webinar which was entitled Dealing with Depression, Warning Signs, Treatment, and Suicide Reduction. And this show is archived on our YouTube channel, and you can watch that at your convenience by going to YouTube and just putting Boulder Psychological Services in the search box. Today we're going to be focusing on how we diagnose depression. We're also going to be talking about treating depressive symptoms as well. And, you know, when we think about depression, one of the things that we have to keep in mind is that depression and sadness are normal emotions. And so I hope what you come away with after our presentation today is a better sense as to kind of where we draw the line, how we determine if someone is experiencing significant depression, what we might call clinical depression, and might require treatment. This is very important because I think that a lot of people who experience the symptoms of depression perhaps wait a little longer than they should to get treatment. And of course, with this disorder, the longer it remains untreated, the more serious the symptoms become, and we really want to intervene as early as possible to prevent things from getting worse and to help that person get back on track. We're going to be talking about some different types of mood disorders, and I'd like to just go over that briefly with you right now. The first one is called major depressive disorder, and this can be either a single episode, so if it's the first occurrence, or it can be recurrent, meaning that it's happened before. We've had these episodic depressive symptoms in the past. There's also another diagnosis that we use. Up until recently, we referred to it as dysthymia, and now it is being called persistent depressive disorder. And the basic difference between major depression and dysthymia, or persistent depressive disorder, is that with major depression, we expect the symptoms to be more episodic. So we expect it to kind of be ups and downs, where the person is feeling good for a period of time, and then they sink into a depressive episode, but then they eventually come out of that episode again. Another symptom of major depression is that we see the depressed mood most of the day, nearly every day, for at least 2 weeks in a row. This is a very helpful diagnostic tool because for most of us, when we experience normal depression or sadness, it does not last most of the day, every day, for at least 2 weeks. So this is very helpful in terms of differentiating what's normal and what needs to be treated. And then dysthymia, or persistent depressive disorder, there we're looking for more of a chronic depression that's lasted at least 2 years and that the person has felt sad more days than not, the majority of time over a 2-year period. This, too, is uncharacteristic of normal sadness and depression and helps us to make that differentiation. I'd like to go over our first slide entitled General Symptoms of Depression. And this will be something that will be helpful for you to just get a sense as to some of the symptoms that we look for. First of all, of course, we look for sad or irritable mood. And one thing to keep in mind about that is for adults, we certainly expect to see that sad mood. But specific to children and adolescents, we can sometimes diagnose depression without sad mood at all, believe it or not, if we have a high degree of irritability. This is not true of adults. It's true specifically for children and adolescents, a high degree of irritability, because what we find, for example, when I meet with children and adolescents who have anger issues, for example, I always assess for depression, and a significant percentage of the time, in fact, these children and teens are depressed. And they're kind of acting out their feelings, if you will, with an irritable mood. The other symptom that you can see on your screen, which is also a very common marker of depression, and this would be true of children, adolescents, and adults, is loss of interest in activities once enjoyed. I met with a young woman recently, an adolescent, who was very involved in swimming, for example, and during her period of depression, which she was experiencing, she lost interest, even though it was something that she really enjoyed and something that she's looking forward to returning to. But she just did not have the interest, the energy to continue with that activity. Another feature that we see are changes in appetite or weight. So we might see weight gain, we might see weight loss. And this is another characteristic. We don't always see it, but we often see it. Similarly, we usually see sleep difficulties. And this is fairly common, where a person will have difficulty sleeping, getting to sleep, or oversleep, sleep a large percentage of the day. These are also indicators of possible depression. And then the next symptom on your slide, slow or agitated movement. And it can kind of go either way. The person may, be just doing everything in a very slow kind of a process, or it might be in an agitated kind of a way. And remember that we have irritability as part of the diagnostic criteria. Very commonly, we also see a loss of energy with folks experiencing clinical depression. And this is a challenge in terms of treatment, and we're going to talk about that in a little while. In other words, if they don't have energy, how can they benefit from treatment like counseling? So we'll discuss that in a moment as well. And then oftentimes feelings of worthlessness or guilt, emptiness, a lot of sort of negative self-statements, feeling bad about oneself. This is also very common with depression as well. And then finally, and very importantly for children and adolescents, is the issue of difficulty concentrating. The adolescent girl that I mentioned that I assessed recently, there was a lot of concern that she had ADHD, and she technically met the criteria for ADHD. However, when we looked carefully at her symptoms, it became very clear that her concentration difficulties were a function of depression. And this is something that we can differentiate through psychological testing. I want to speak for a moment about some other mood disorders. But first, I'd like to go to the next slide and talk about some of the symptoms that are unique to children and adolescents so that we can keep these in mind in terms of our kids. As I mentioned before, we want to look for signs of increased irritability, anger, hostility, and this is very important because I think for a parent, when you're especially adolescent, is irritable and angry and hostile, we think about consequences. We don't think about maybe they have an underlying mood disorder, and that's why I'm hoping that this information is useful to you and your family so that you're aware of this very important distinction when it comes to depression diagnosis in children and adolescents. We'll often see a decline in school performance. Similarly, for adults, you'll see a decline in work performance. And also increased absences from school are also fairly common. Lack of interest in spending time with friends or family. We know how social adolescents are, for example, and when we see a dialing back of interest in being involved with their social groups, this is often something that we want to better understand and determine if this is part of a depressive presentation. Similarly, talks or efforts to run away from home. We often see this too with kids that are experiencing mood disorders, as well as social isolation, poor communication, extreme sensitivity to rejection or failure, some reckless behaviors, as well as neglecting of clothes and appearance. And I know some of these symptoms are sort of normal adolescent symptoms. So we really want to consider sort of the number of symptoms that we're experiencing and observing to help us to determine if this is a reason for cause and intervention. Let's talk now about some other mood disorders briefly. Another category of mood disorders are bipolar disorders, and there's a couple of different types that I'm going to very briefly go over. One of the caveats that I want to mention in terms of bipolar disorder is that in the last several years, the diagnostic criteria have changed somewhat, particularly with children and adolescents, and this, unfortunately, in my opinion, has resulted in an overdiagnosis of bipolar disorder in children and especially adolescents. And part of the challenge for the diagnostician is that what adolescent isn't moody? And is that moodiness normal, or is it a sign of a significant mood disorder? And so sometimes this is unfortunately overdiagnosed. So we want to be very thoughtful and careful because without exception, when we have a diagnosis of bipolar disorder, medication is almost always a part of the treatment plan. And we certainly don't want to provide our children and adolescents with very serious psychotropic medications if they're not indicated or necessary. There are two kinds of bipolar disorder, bipolar disorder 1 and bipolar disorder 2. I'm just going to briefly discuss this. Really, the difference between the two is those manic or what we call hypomanic episodes. So the symptoms for depression are consistent in both bipolar 1 and bipolar 2. But in bipolar 1, we really are anticipating manic episodes. And this is a more extreme version than what we consider hypomanic episodes. And so here's an example that I found recently that might help explain it. Hank, when he has hypomanic episodes, is exceptionally cheerful, needs only 3 hours of sleep instead of his usual 7, spends more money than he safely should, and speaks far more rapidly than usual, along with the other symptoms of hypomania. The behavior is noticeably different from his own stable mood, yet, there are cheerful people in the world who need less sleep, spend a lot of time talking fast, and don't have bipolar disorder, and so for this gentleman it would be considered abnormal. Let's compare that to Hank's friend Robert, who has manic episodes, is out of control happy, even during serious events. He bursts out laughing disruptively during a funeral. He ran around outside at midnight shouting how much he loved all of his neighbors, along with the other symptoms of mania. These behaviors would be abnormal for anyone. So when we talk about hypomanic and manic episodes, really we're talking about the degree of symptoms. This is particularly true when we see psychotic symptoms. This can sometimes be the case with bipolar disorder. And if we do see psychotic symptoms, which involve delusions, hallucinations, then it's clearly a manic episode versus a hypomanic episode. And we're going to talk about medication in terms of treatment in a moment, but I just want to mention while we're talking about bipolar disorder that one of the big challenges in treating folks with bipolar disorder is they need to be on medication all the time to kind of keep that even mood, but subjectively, many people that are on bipolar medication don't really like the way it makes them feel. They feel kind of flat emotionally. And a lot of them really miss elements of that manic or hypomanic episode because a lot of it is kind of subjectively feels good to the person. They have all that energy, they have all that sort of false confidence. They usually end up getting in trouble in terms of impulsive behaviors, but they kind of miss those feelings. And so a common treatment obstacle for clinicians treating folks with bipolar disorder is medication compliance, because again, stereotypically, it's not unusual for the person to go off medication and then shortly thereafter run into problems, typically in terms of those manic kinds of episodes, let alone the depression symptoms getting worse. Let's talk now about diagnosing depression. And again, let's remember that depression is a normal feeling. And so let's talk a little bit more about how we differentiate normal depression or sadness from clinical depression or sadness. One of the key things that we look at, of course, is the severity of symptoms. So keep in mind what I mentioned earlier in terms of major depression, for example, where we expect the person to feel sad most of the day, nearly every day, for 2 weeks in a row. That usually differentiates those two populations. Similarly, with dysthymia or persistent depressed mood, we would anticipate at least more sad days than not over a 2-year period. Again, unusual for the normal person that experiences depression for a brief amount of time. And then very importantly, we also look at interference with daily functioning. The person is experiencing mood disorders to such a degree that they cannot really meet their responsibilities socially, vocationally, educationally. So again, for a child or adolescent, that's part of why we see the frequent absences in school. They're tired, they don't have the energy to get out of bed, they just don't have the interest all of a sudden to go to school. Similarly with adults, they may run into some problems getting to work, maintaining their responsibilities at work, etc. And so we try to do a very careful clinical interview with the client or patient to really get a sense of their history and also their day-to-day functioning and where there are areas that in the recent past typically have been compromised because of their debilitating mood disorder. And there are many diagnostic challenges in making a diagnosis of a mood disorder. As we talked about before, children and adolescents, being moody, and is that something that we can label major depression or dysthymia? We have to be very thoughtful and careful about that. There's also a lot of reasons in life why we become depressed. For example, when we're experiencing grief. Grief is a normal process. Of course, we're going to feel depressed when we're grieving. Does that person have clinical depression? No. And the reason for that is that it's more of what we would call an adjustment reaction. Adjustment reactions are typically fairly short-term in nature, 6 months to a year, and they have an obvious cause. In other words, the person did not feel depressed at all until the death of a relative, for example, and then they understandably went into a period of depression for several months, maybe 6 months, more or less. And that's a very different disorder than clinical depression, although it can lead to it. If someone has trouble moving through the stages of grief, and now it's 8 months, 10 months, a year later, and man, they are just as depressed or worse than they were, it might transition into a mood disorder. So we want to be very thoughtful and careful about that as well in terms of, again, doing a really careful history taking and finding out if there have been some traumatic events that have resulted in these depressed mood symptoms. Similarly, there could be a trauma that has occurred. This is one of the things that we do see with depression, that sometimes it's the result of a traumatic event. And so there, too, we want to be very thoughtful about doing a careful workup and getting a careful history. Finally, another sort of confounding variable is substance use. Substance use can mimic a wide range of mental illnesses. So, for example, let's take marijuana as an example. We know that marijuana can actually fuel depression in someone that's not depressed at all. If they are chronic, heavy marijuana users, that can often result in the symptoms of depression. Similarly, many people who are experiencing mood disorders and other psychiatric difficulties will what we call self-medicate. And so they will use alcohol or other substances to try to feel better, to try to cope. For example, it's very common to meet with high school students who abuse substances because they want to feel more comfortable socially. And so they might have an underlying social anxiety issue that they're self-medicating or self-treating with various substances. Oftentimes, folks that are experiencing depression will utilize alcohol to try to feel better. It's the worst thing you can do because alcohol itself is actually a depressant. And while it might have some very short-term temporary benefit, it's actually going to create even more depression. And so this is also important information for us to have because if substance abuse is fueling the mood disorder, well, we want to really treat that substance abuse and not be aware of that and just see it as depression. And so these are some of the ways that we have to be very thoughtful when we're making the diagnosis of depression. I also want to let everyone know, especially if you're viewing this live, you can get on our website, boulderpsychologicalservices.com, click on our events calendar, go to this event, and there's a form there. You can email questions to me live, and I would love to get your questions and try to answer them. So if you are watching live, you have access to a computer, and you have any question at all about this topic, please submit it. I'll get it, and I will try to respond to it. I'd like to talk now about treatment for depression. The good news is depression is a very treatable disorder. We have tremendously effective techniques to treat depression in terms of psychotherapy, and for some folks, medication can be a useful treatment adjunct as well. Simply because in talk therapy, we really try to help folks to express their feelings, in and of itself, that can be a very useful tool in reducing the symptoms of depression, providing that person with a clinical expert who can really listen and hear and encourage the person to be expressing those feelings. A lot of times, depression is developed because we are not good at expressing our feelings and they build up. Typically, when this occurs, one of two things happen. Either we see significant depression occur, so this would be when we're taking all those feelings and turning them inward, or we could see some acting out anger kinds of behaviors, which would be taking all those negative feelings that are unresolved and extending them outward. While it is really a stereotype, and there are certainly many exceptions to the rule, oftentimes with girls and women, we see this pattern of internalizing negative feelings that are not addressed and resulting in depressive symptoms. And with boys and men, again, stereotypically, but not always, we see this more acting out kind of behavior. And the reality is, for all of us, if we have a negative emotional experience and we don't allow it to be expressed, we just kind of sweep it under the rug, assume that it'll just go away on its own, it doesn't work that way. And so it becomes like a pressure cooker with more and more negative feelings building up, building up, building up. And sooner or later, something has to change. And that's when we usually see the trigger for increased depressive symptoms or increased anger kinds of behavior as well. Sometimes we see a little bit of both too. One of the most effective treatments for depression is known as cognitive behavior therapy, or CBT for short. And I just want to speak for a moment about this strategy. One of the things that we believe in terms of cognitive therapy is that when we are feeling any kind of negative mood, we typically attribute it to something going on in our life. That person said something mean to me, and so I felt angry or sad. The cornerstone idea of cognitive therapy is that there's an intervening variable that occurs that we're usually not aware of. And so we have the event that occurs, we have the emotional feelings that we end up with, but in between, we're evaluating, we're talking to ourselves about what occurred. And believe it or not, it is those thoughts that fuel those mood symptoms. And so depending on how I react to that, I'm going to have a very different emotional experience. For example, I'm from New York originally, and I'm not proud to say that us New Yorkers are not the best drivers in the world. And when I was going to graduate school in New York, I would get on the highway, people would cut me off. I would get very angry. I would think to myself, how dare they cut me off? How rude. I can't believe they did that. To be honest, I would even have thoughts of I should follow them. And, I am the least violent person I know. Had I done that, I'm sure I would have gotten beat up. But in that moment, and I think you all know what I mean, right? We all have those moments where we have those kind of thoughts go through our head. Then, when I was in graduate school, I learned about IQ testing, and I found out that an IQ of 100 is at the 50th percentile. This was shocking news to me because you know what that means? Half of us have an IQ under 100. None of us want to believe that, but there's half of us out there with an IQ under 100. Why do I mention this? Because subsequent to learning this, I would be out on the highway again. Someone would cut me off in traffic, but this time I would say to myself, maybe they're one of those people. Maybe they're doing the best they can. Now, I didn't know for sure that that was true, but I have to tell you my reaction to the same event was significantly different. I didn't get as angry. I didn't get as upset. I felt sympathy. Whether it was appropriate or not, another story. But it's a good example of the fact that the event is something that we can control in terms of our emotional reaction. And so that's just one little example of the power of cognitive behavior therapy. Unfortunately for all of us humans, when left to our own devices, we will think in a negative way. This is true about every area of our life, including our parenting, our sense of self, etc. And so what cognitive behavior therapy helps us to do is to become more aware of these habits, to challenge them, to change them, and to change our thinking to make it more healthy and more appropriate so that we don't experience these kinds of negative moods that we don't need to experience. As I mentioned before, medication is often something that we consider when treating depression. And, I'm sure a lot of clinicians would have a different view about this. I'll give you mine. I can tell you that while I'm very conservative with psychotropic medication for anyone, especially children and adolescents, there are certainly many occasions in my experience where it was a wonderful blessing for that person. And so this is something that is very useful for many folks experiencing severe depression, because part of what happens, as I mentioned earlier, is they may have very little energy to do anything, to even get out of bed. And so the benefit of medication in those more severe cases is it helps to, within a few weeks, reduce those symptoms of depression. The person has more energy and then can benefit more from strategies like cognitive behavioral therapy, other kinds of talk therapy approaches, etc. And so very often, if the depression is severe, especially if there's any kind of suicidal thinking, etc., medication is very important, and we want that to be part of our treatment plan. If and when the client benefits from talk therapy, we can start dialing down the medication. Hopefully, they won't need the medication at all. If it is a mood disorder that's biochemical in nature, maybe there's a strong family history of depression, etc., and if there does seem to be biochemical factors, one of the ways that I try to determine that is I'll ask the person if, when they feel sad, is it usually for some reason? Is it usually because of something going on in their life, or does it feel just out of the blue? They feel depressed, they don't even know why. When that's the case, I start wondering about more of a biochemical basis. The last thing I want to mention in terms of treatment is, believe it or not, exercise, tremendous benefit. It helps all things, depression, anxiety, obviously our physical health and well-being. And so that's always a great recommendation for someone suffering from a mood disorder, to really encourage them, even if it's just a 10-minute walk. I mean, any kind of exercise is extremely helpful, extremely beneficial. As I look to see questions that have come in, I want to put another slide up on the screen in terms of local counseling resources that are available to you in the community. And so we're going to get that slide up, and I'm going to go over that with you. You'll see on the slide that we have Mental Health Partners. This is a local organization. They used to be called the Mental Health Center of Boulder County. and you have their phone number and website information. If you qualify for their services, this is really services for folks that are very financially challenged in our community. A great resource, tremendous resources through the mental health partners. We're also very fortunate to have a psychiatric hospital in our community. As you may or may not know, more and more psychiatric hospitals are closing around the country, and we're very lucky in Louisville to have Centennial Peaks Hospital. Centennial Peaks, 24/7 assessment. You have concerns about yourself or your adolescent. You can go there 24 hours a day, 7 days a week, although it's very helpful to call first and let them know so they're prepared for you. And if needed, you can spend some time in the hospital when they put you on medication and help stabilize that medication, a fantastic resource if needed. We also have the Second Wind Fund of Boulder County. This is a great organization that serves primarily children and adolescents that are referred through the school district by counselors, and they will actually pay the cost of counseling with a licensed mental health professional if they see severe signs of depression, possible suicide risk. There's also the Boulder Counseling Cooperative, another organization for lower income neighbors in our community, with counseling starting at $20 per session with a licensed mental health professional. You can find out more about the co-op by going to the website bouldercounseling.org. And our organization, boulderpsychologicalservices.com, another resource for a wide range of therapeutic issues. And finally, the Boulder County Prevention and Intervention Program. This is a wonderful organization that's in most of our high schools, some of our middle schools, where there's actually a mental health professional and interventionist in that building, trained in terms of assessing for suicide, depression, etc. A wonderful resource. And I have the phone number and the web address if you want to find out more about that organization as well. If you need this information, you can watch this show. This show will be archived probably within a week or two on our YouTube channel. Again, Boulder Psychological Services YouTube channel, and you can get this information. Again, you can always contact me directly at info@boulderpsychologicalservices.com. Given that we haven't had any questions come in, I would just like to put up the next slide in terms of some of the upcoming events that we'll be offering in the community, the upcoming BPS presentations. And you can see that we have the Teen Depression Talk in Broomfield on October 20th, the Adults Managing Depression workshop at Louisville Library on October 21st, and one that focuses on children and how they can improve their mood at the Meadows Branch Library on October 27th. I'm going to leave that slide. We're going to take that slide down. And I also just want to take a moment. Oh, there it's back again. I just want to take a moment to thank our sponsors, without whose help this show would not be possible. The Boulder Valley School District, and particularly our technology diva, Lisa Collins. The Daily Camera, Centennial Peaks Hospital, the Boulder County Healthy Youth Alliance, Boulder Counseling Cooperative, and the Temple Grandin School. Thanks to all of you for your help, as well as the Hope Coalition and the Parent Engagement Network. We couldn't provide these without you. I hope you've gotten some useful information from our show today, and I look forward to speaking to you soon. We're going to be doing our next TV show on November 20th, entitled, "Oh No, a Teenage Brain Has Taken Over My Child," where you can learn about the latest research on teen brain development. So join us for that show on November 20th. Thanks for being with us today. Look forward to speaking to you soon. Bye-bye.
And now the planet's done its bowing down. And soon the growth returns to follow ground. But I know what's churning underneath the snow. And I love my baby, and we've miles to go. Hey, 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 I'm okay. Be with me. We'll beat this, can't you see? So wait a while, winter time.